Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Pain is one of the most common reasons patients call 911. It is also one of the most misunderstood. For decades in pre-hospital medicine, the approach to pain has often been simple. Find the opioid, treat the number, transport the patient. But medicine evolves, and in 2026, we are beginning to understand something important. Pain is not just a symptom, it is a physiological stress response. It is a predictor of morbidity, and in some cases, untreated pain can worsen outcomes. Tonight's episode is about modern pain management. Not just what we give, but how we think.
Pain control is one of the most requested skills in EMS education.
And one of the most controversial.
Today we're going to talk about evidence, pharmacology, myths, and how the future of analgesia is shifting beyond a fentanyl-only mindset.
Okay, let's talk about why pain matters, and let's talk about the trickle effect that pain has on the body. So you will see, in some cases, a sympathetic activation, tachycardia, hypertension, increased oxygen consumption, hypercoagulability, immune modulation. Severe untreated pain has been associated with worsened trauma outcomes, increased delirium risk, chronic pain syndromes, and PTSD development. Modern literature increasingly recognizes pain as a time-sensitive physiological condition, not simply a comfort issue.
Pain is not cosmetic medicine.
It can even be hemodynamic medicine, and we love in this field to downplay pain. It is a little bizarre to me. If you tell me you have pain, I'm gonna treat your pain. Do I believe that we need more options?
Yes.
Absolutely. But I have what I have, and I'm gonna work with what I have. Do I think sometimes there's better options and worse options for situations? Yes. But if you are having significant pain, you tell me you're having significant pain, I am going to treat your pain.
For sure. And I think that's why, for so long, EMS's pain control options have just been opiates.
Yeah.
And because of that, we became very resistant to giving pain control. Like, you tell me your tummy hurts or you have a headache, and I'm going to give you fentanyl. I'm like, that doesn't match.
That seems intense.
We haven't even tried 800 milligrams of ibuprofen, homie. And so, I think that's why we became so resistant to it. But there are so many options now.
100%.
And so we got to change our mindset, I think.
And because the mindset has always been, opioid-centric practice, let's talk about the limitations of that. So, fentanyl became popular because it has a rapid onset, it has a short duration, and it has relative cardiovascular stability. However, opioid-centric models, they create problems. There is always the respiratory depression risk, especially in elderly, head injuries, or maybe polysubstance use. You may need repeated dosing cycles, and evidence suggests opioid exposure may increase pain sensitivity in some patients. And have you ever given pain medicine and everything gets worse? Because I have.
Mm-hmm.
I absolutely have.
Mm-hmm.
And there's also just societal / cultural barriers, especially when people hear fentanyl.
Yeah.
They get really nervous. And even if you explain it to them with the best science and the most layman terms possible, I've had patients refuse anyway because, that is an extreme intervention, right? And providers sometimes have fear. Addiction people say this often, your one dose of pre-hospital medication is not going to be the cause of someone's addiction.
We have to make you have to make a lot of decisions down the road. Now, I will say someone's first opiate exposure, if they very much enjoy it, may make them consider trying that again, maybe sometime down the road. That is probably something their brain would have come to a conclusion without your one dose of pain control for their broken leg.
Yes.
So, like, you can't put that on yourself.
100%. And then I have heard when we arrive at facilities that sometimes, physicians may be worried about altered mental status and things like that when we treat pain, depending on what we treat with. But modern EMS systems are exploring a lot of different options now. There's a lot of things that maybe even 5 years ago were not even probably thought of on an ambulance.
Yeah. So, speaking of, we talk about the ketamine revolution. So
You either
ketamine,
love it or you hate it.
I know. Ketamine has become one of the most discussed analgesics in pre-hospital care. So its mechanism, how it works, is it's an NMDA receptor antagonist. So it reduces central sensation, preserves airway reflexes, which is why a lot of people like it, and it supports blood pressure. So you don't have a lot of the problems that we see with opiates. It actually is kind of the opposite effect.
For sure.
So your analgesic dosing, they range, but the doses that are commonly discussed is 0.1 to 0.3 milligrams per kilogram IV, or 0.5 to 1 milligrams per kilogram IM. So benefits supported in multiple studies are superior pain reduction in trauma, opioid sparing effects, and minimal respiratory depression. Some adverse considerations is emergence reactions, and if you have never seen an emergence reaction, they are wild.
They are wild.
And sometimes very rascally.
Frightening or hilarious,
and
depending.
in trauma patients can sometimes be
not ideal.
Not ideal. A bit dangerous sometimes, depending on what limbs are broken. Will flail them about.
Yes.
Yep.
It can also cause nausea, tachycardia, and increased secretions, which you do have to be mindful of, because even though they can control their own airway, they are off in la la land, and so sometimes you may need to suction a little bit.
I mean, ketamine really has changed the conversation for sure.
And it's absolutely given EMS another tool.
And there's plenty more options where that came from. Modern EMS systems are exploring some fun ones, like nitrous oxide is making a comeback.
I know.
Yeah.
They snatched it from us.
I like it. I think it's a great option, especially for pediatric patients.
Yeah.
There's all kinds of systems for nitrous oxide delivery. It's rapid onset. It is self-titrated, so the patient is the only one.
They can hold it.
Yep. And then useful in procedural pain management as well. IV Tylenol, chef's kiss. Chef's kiss. I've had it myself, and I've had it post-surgical for post-surgical pain.
Wild.
And it works so well. I've been in the hospital and be like, "Can I have IV Tylenol?" And they usually say yes. Sometimes they are like, "What?"
You're like, I don't want that fentanyl, but I will take some IV Tylenol.
Yes, I would love that IV Tylenol.
That'd be great.
Yeah, it's effective for mild to moderate pain. It is obviously opioid sparing, and it has minimal, if any, hemodynamic effect.
Which is great.
And it's safe in most patient populations.
Mm-hmm.
And then this is one I'm just going to mention because you might see it if you're transferring a patient, or maybe in the ER. So, regional anesthesia, so that means nerve blocks and things like that. So they'll do that occasionally in emergency rooms, especially if a patient has maybe they have a little bit of a time before they are going to the OR or whatever. They can do that. An anesthesiologist can do that. But it's a good option, and you might encounter a patient, and a lot of the times your assessment will be different because they've had this nerve block, so just keep that in mind.
So we would not be talking about pain control if we did not address special populations. First and foremost, the GERIs are geriatric patients. So they have a higher opioid sensitivity. So you do want to be mindful of your dosing. A lot of times we start at a lower dose with our geriatric patients. They also have a greater delirium risk. With head injuries, head injury patients, you want to avoid hypoventilation and hypotension. And so with that, opioids, you can see why they might cause a problem. Burn patients Burn patients are going to require aggressive multimodal analgesia. If you have ever had a patient with a significant body surface area burn, like greater than 60-70%, you could throw your entire narcotics box at them and they will still be awake. They a lot of times will fight through that sedation pretty aggressively because the level of that pain and the distress their body's in.
Does anybody remember that time I had a burn transfer and they only gave him 50 of fentanyl?
Oh my gosh.
Do you guys
don't remember that?
Yeah, that's all I did.
Okay, well.
So I fixed that.
Yes, Austin and I had a burn patient that was like, my gosh, like 90%. Like, I mean, we were just like everything.
Yeah.
And he could not give him enough meds.
Yeah,
Like,
I mean, it's
it
you
was
really
everything.
if you get behind,
Yeah,
like,
there's no catching up.
Yeah.
And then our last, but certainly not only ones, but the most popular of our specialized patient populations is pediatric patients. Under treatment for peds is very common. So an under treatment of pain.
Well, that's because if they're under the age of 2, they don't feel pain.
Right.
exactly.
And that's how a lot of people behave. And I think that a big part of it is that most of our treatment options for pain are IV. And a lot of providers are pretty iffy on starting lines on kids if it's just for pain control. They don't like to do that. But more and more services are starting to carry like rectal options, oral options, and things like that for kids to be able to control pain better.
Yeah.
Why don't we talk about Toradol real quick?
Yes, please.
Oh, yeah.
So, I have worked for many a doctor. Some love the Toradol. Some would rather execute you than allow you to give the Toradol, and I'm not even kidding. There's extreme feelings about Toradol. So it is an NSAID, and that is why people have feelings about it. So it's a non-steroidal anti-inflammatory, which does have it just depends on the study you look at, but can increase bleeding, and they worry about patients who are perioperative, pre-op patients, things like that. But I like it because I've called many times for orders to give Toradol because the place that had it where I worked, they only had it for like suspected kidney stones. I'm like,
That's it?
yep, that's it. But I called all the time. I'd be like, okay, this patient has XYZ. Can I give Toradol? This patient has this. I never had a doctor tell me no.
Yeah, no.
It's really, I mean,
And when you work in the ER,
musculoskeletal injuries,
yes. And when you work in the ER, every patient that comes in with any pain
gets Toradol.
gets Toradol. 15 Toradol.
Mm-hmm.
Like every single one of them.
Yeah.
And so it is sometimes wild when you work at an EMS agency where they're like, no, Toradol's bad.
It's evil.
I'm like, if this person even walks into a hospital in our county, they're going to get Toradol.
A lot of pain, I wouldn't say most. A lot of pain is inflammatory. So it just depends what you're treating, but like musculoskeletal like strains and things like that. I called once because I had a patient who she just had jaw pain. She had jaw pain and she had a toothache. And I called and I was like, hey doc, it's going to be an hour before I get to you. I don't have orders for this, but I have Toradol. And I also have these extreme pain medications. Can I give Toradol? And he was like, yeah, of course.
Of course.
Why are you calling me? I told you
I don't know.
orders.
I have to.
But
that is one thing.
Yeah.
This is not super on topic, but that is one thing that I wish they would explain to physicians in the ED a little better. That, like, I am not calling you for orders because I don't know what to do. I'm calling you for orders because my protocol specifically says contact medical direction for orders.
Correct.
And I wish that they knew that a little bit better because sometimes I feel like they just by you calling for orders, they think that you don't know what you're doing, so they're less likely to give you the order.
why do they not learn that in school? Because that's what part of their job is.
Right. And
Seems
so I just
odd.
feel like if they understood that, like, I have a literal book that says call medical control, because we are not lucky enough to have, like, medical direction that is specifically our medical direction. Like most services, we call the local hospital. That's our medical control. And so sometimes they just don't be understanding.
Yeah, I think they get annoyed sometimes.
Like, why would you call me for that? I'm like, honestly, I don't know. Please
I
talk
know.
to my medical director.
I
Because
would like
this
to
is so silly.
Consult Dr. Insert Name. Please do that.
Please do that.
You have my permission. However, this is the crossroads we are at right now.
Because
Yeah.
I would love to not have to call
We are
you for
unfortunately
this.
having to cross this bridge. So
And you know who our new hero is?
Dun, 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 dun.
Droperidol has entered the chat. So, if you don't know what droperidol is, it's becoming increasingly popular in ERs, but definitely in the pre-hospital setting. It's actually an antipsychotic, alright? So, it's in the same family as haloperidol, which means this is a great medication, in my humble opinion, to keep on an ambulance because it has 3 uses for you, okay? It works on dopamine receptors, okay? So, it has antiemetic, sedative, and anxiolytic effects, and off-brand, it has been used for pain management as well. So, you got abdominal pain? That sounds like a pretty good one.
That sounds like a win-win to me.
Yeah, I mean, it has some concerns due to, like, QT prolongation, but, like, we have other medications that have the same concerns.
Exactly.
So, treat with caution, but it is fast, it's predictable, and it's versatile. So, why would we not carry something that's so versatile on an ambulance? Because we only have so much space. Some things it's used for: agitation, metabolic behavioral emergencies, nausea, vomiting, migraine headaches. It's usually part of a migraine cocktail. Pain and anxiety, and it's usually given at a dose of 5 to 10 milligrams, depending if it's IV or IM. And then nausea and migraine doses are only 0.5 to 2.5 milligrams IV typically, and its onset is like 3 to 5 minutes, and it lasts about 4 hours. So
That's fantastic.
That is great.
I think it's pretty great, right? Compared to haloperidol, it has a faster onset, and it's more sedating, but like in a controlled way. And it actually, compared to benzos, obviously, it has less respiratory depression, and it's normally a more predictable onset and offset of sedation. So it's a very, like, it's not an intense, like, on-off. So, again, like, the QT prolongation can be an issue, but, I mean, it's kind of like the wonder drug of the moment.
Yeah, it does sound pretty fantastic.
Yeah.
Well, heck yeah.
It's good because it would probably be great for, like, the middle
The middle of the road.
Yeah.
Anxiety person.
Especially, like, there's some things that, which we didn't really discuss, like, there's some things that opiates just don't work for.
My stuff doesn't.
Yeah. Like, especially, like, long bone fractures and skeletal injuries.
Fentanyl is stupid.
Yes. Like,
for
the
that.
amount of times that I've had, like, just, like, a tib-fib break or a radius ulna break or something that is, you're like, ugh.
Yeah.
I can give them 200 of fentanyl and they're still like, ow.
Mm-hmm.
Yeah.
Like,
Honestly,
it does not.
fentanyl I have seen anecdotally work better for, like, medical related pain.
Yes. I'm honestly surprised now
Abdominal pain, whatever.
when I give fentanyl and patients are like, I feel better. I'm just expecting them to still be like, owie. But it would be so nice to have an option that is not that. And for patients that, like, you know, those patients you get that have a migraine and they look absolutely miserable.
Yeah, they've had a migraine for like 2 days and now they can't move.
And I would be just like crumbled in a ball on the floor because I'm a big baby about headaches and I cannot
headaches.
imagine. I always feel terrible because, like, we don't really carry appropriate medications for that.
Right.
No. And that's why droperidol is kind of like a winner of the moment. And I'm sure there's a chance in like 5 years we're going to change our mind. But based on the current research and the data we have and what it can treat, why wouldn't you have it on your ambulance?
Yeah, it sounds great.
It's fairly safe. You know, it treats several things. I mean, it's a yes for me. And it's great. A lot of places now are just carrying Zofran, or maybe they still have Phenergan. But, like, this is a good option if you want to replace Phenergan.
Mm-hmm.
Or if you don't have anything beyond Zofran.
Yeah. So, all of that to say,
Woohoo.
the future of pain management in EMS is looking up. But in order for it to keep looking up, we have to keep moving forward. And what that looks like is having flexibility in our protocols, having individualized analgesia, being able to intervene earlier, and being able to have some sort of combination therapy, i.e. being able to kind of pick and choose and have some adjunctive medications. Because remember, the goal is not just comfort, it is physiological optimization.
And in 2026, pain management is no longer about just one drug. It's about understanding the patient's physiology, choosing the right tool, and remembering that relieving pain is not weakness in medicine. It is clinical excellence. Mic drop. dropped.
Ba-boom.
If this episode brought you value, take a moment to rate and review the show. It helps more providers find us. Follow Life in Sirens, join our mailing list for exclusive content, and visit lifeinsirenspodcast.com for resources and downloadables built for the modern provider. And if this conversation made you think, send it to your partner, your preceptee, or someone on your crew, because better providers build better systems.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.